All right, let's dive right into this explainer where we're going to unpack the delicate, complex plumbing of veterinary medicine. We'll be looking closely at exactly how diuretics save lives in cases of congestive heart failure. And just as importantly, we're going to lay out the critical rules for safely combining these incredibly powerful drugs. It's literally a terrifying scenario. Picture an animal in acute congestive heart failure. Fluid is building up rapidly in the lungs, and they are essentially drowning from the inside out. When that happens, it becomes an absolute race against time to mobilize that excess fluid and relieve the immense pressure on their failing heart. So, here's our game plan for how we win that race. First, we'll open up the diuretic toolkit. Second, we'll examine loop and osmotic diuretics. Third, thiazides and potassium-sparing agents. Fourth, we'll talk winning combinations. And finally, lethal interactions.
Part 1. The Diuretic Toolkit.
Think of a diuretic as the ultimate physiological release valve. When a heart can't pump effectively anymore, blood backs up, and fluid just starts leaking into places it definitely shouldn't be, like the lungs or the abdomen. A diuretic steps in and forces the kidneys to excrete excess sodium and water. This reduces the total blood volume and takes that heavy, dangerous burden off a failing cardiovascular system. Moving on to Part 2, loop and osmotic diuretics. In the heavy-hitting world of loop diuretics, we've got two main players. Furosemide is your classic, go-to potent loop diuretic. It does its job by blocking sodium and chloride reabsorption right in the thick ascending limb of the kidney's loop of Henle. But right alongside it, we have Torsemide. Now, Torsemide is a newer, much more potent alternative. It's usually reserved for those advanced cases where furosemide just isn't cutting it anymore. But we have to be careful, because with that extra power comes a higher risk. Torsemide carries a significantly greater chance of causing renal insufficiency and severe electrolyte disturbances. Next up, we have osmotic diuretics, like Mannitol. And what's really fascinating about these is how they work. They don't just block sodium, they literally extract water straight out of the intracellular compartments. But here is a massive red flag we need to highlight. Pulling that water out rapidly expands the extracellular volume. So, if you have a patient in congestive heart failure who is already struggling with volume overload, combining a loop diuretic with an osmotic diuretic can be absolutely catastrophic. The osmotic drug will just yank massive amounts of fluid into the vascular space, causing a fatal volume overload on a heart that's already failing. That is exactly why osmotic diuretics are strictly contraindicated for patients with severe renal impairment or those who are severely dehydrated.
Part 3. Thiazides and potassium-sparing agents.
You know, loop diuretics are amazing, but they often aren't enough on their own, or they create secondary problems we have to go in and fix. So we turn to adjuncts like Spironolactone, which is a potassium-sparing diuretic. Now, by itself, it's actually a super weak diuretic. You'd never use it alone to save an animal in acute heart failure, but it is a brilliant partner drug. See, loop diuretics cause the body to flush out tons of potassium. Spironolactone steps in and specifically stops that dangerous loss by blocking aldosterone. And even better, it provides direct cardioprotective antifibrotic effects right to the heart muscle itself. But what happens when a failing heart just stops responding to even high-dose furosemide? It happens, right? The kidney adapts and just stubbornly reabsorbs the sodium further down the line. To counter this, we use a rescue technique called sequential nephron blockade. Basically, we introduce a moderately potent thiazide diuretic, like hydrochlorothiazide. The thiazide hits a completely different section of the kidney's plumbing, the distal convoluted tubule, and blocks the sodium that the loop diuretic missed.
Part 4. Winning combinations.
This is basically your ultimate cheat sheet for combining these drugs. Mixing a loop diuretic with spironolactone, highly recommended. It's the absolute gold standard of care for canine heart failure. But we also have to talk about strict contraindications. Combining a diuretic with an NSAID or an aminoglycoside antibiotic is a hard avoid. These aren't just polite suggestions. They are blaring red alerts for severe, life-threatening complications.
Which brings us nicely to Part 5, lethal interactions.
Violating the rulebook and mixing the wrong drugs can turn a life-saving intervention into a fatal event in no time. For example, diuretics reduce overall blood volume, right? Well, NSAIDs constrict renal and gastrointestinal blood vessels. Put them together, and they literally starve the gastrointestinal mucosa of blood flow. The consequences are horrific. Endoscopies of patients given this combo often reveals severe, life-threatening duodenal ulcerations directly caused by this incompatible mix. And we've got to be just as careful with antibiotics. If you mix a loop diuretic with an aminoglycoside antibiotic like gentamicin, you are massively amplifying the toxic effects of both medications. This combination viciously attacks the kidneys, leading to serious nephrotoxicity. And simultaneously, it damages the inner ear, which can easily result in permanent deafness for the animal. Hey, it's not just about how these drugs interact inside the body's organs. Even the physical combination of the drugs, right there in a syringe or an IV line, is risky. Furosemide is a mildly alkaline product. Butyrophanol, which is a really common sedative, is acidic. If you accidentally mix them in the same IV line, they instantly form a highly dangerous cloudy precipitate. If that precipitate gets injected, it can fatally occlude cerebral or pulmonary blood vessels. You literally always have to flush the line. Critically ill patients are already walking a tightrope, and they are at a huge risk for adverse drug events because they're getting multiple, very powerful medications all at once. When veterinary staff have to manipulate these chemical tools, especially in extra-label ways, the risk of a fatal interaction just skyrockets. Diligence here is absolutely everything. So ultimately, managing congestive heart failure is a massive, high-stakes balancing act. We have these incredible tools to save an animal from drowning in their own fluids, but every single intervention carries a cost. It leaves us to constantly ask the toughest question: how can we best relieve a failing heart today while making absolutely sure we ensure the long-term survival of the kidneys tomorrow? Thanks so much for joining me on this explainer, and I really hope this cleared up some of the complex plumbing behind veterinary diuretics.